So thank you very much. And at the outset, I'd like to thank APAO, AIOC, and Dr. Rashman Gandhi for giving me an opportunity to participate in this session. So from red eyes and red nose, we'll come to some white eyes and challenges. And I'm very fortunate to practice in Hyderabad because I have Rashman Gandhi in my city. So I can just pass on the challenges to him. So let's go through some of the cases. We will start with thyroid because that is one challenging condition with diplopia, and then move on to trauma. Um, so as Dr. Clementine said, we I asked ChatGPT for a nice cartoon or an image of diplopia, and this is what they gave me. So I kept adding more and more words to make it more specific. But anyway, so this is diplopia according to ChatGPT. But let's go on to the first case. So this is a 56-year-old gentleman, Mr. CB. He is a patient of thyroid eye disease for over 4 years. He's in the chronic phase now, or the fibrotic phase. He presents, as we can see very clearly, with a very large angle esotropia. His eyes, his right eye is sort of fixed in that adducted and slightly hypotropic position. He has a esotropia which on Krimsky he just cannot fix. It measures about 80 prism diopters. He has an abduction of -5, elevation of -6, as you can see in these, and he's also a high myope. So many a times when you see both high myopia and thyroid eye disease, we want to know what exactly is the pathology going on. Why is he having the diplopia? Is it the myopia that is causing the globe to be so large that is displacing the muscles, or is it really the thyroid that is actually acting and infiltrating on the muscles? We got an MRI done. I don't have these images, but they showed really large and enlarged medial inferior, pretty much all the muscles, but it was slightly asymmetric. So then he moved on to have surgery for the right eye. At that time, he didn't want any surgery for the left eye because he was kind of fixing with that left eye. He went a large medial rectus and inferior rectus recession. This is his photos. So he first presented in 2023. This was last year, 2024, around this time. And there was a significant improvement. The recession was kind of supramaximal for the medial rectus and inferior because we don't always do 8, but then I just didn't know how to get anywhere close to that 80. So he now had a esotropia of 45 and a small right hypotropia. The motility was somewhat better, but there is still that limitation of abduction that you can see in the right eye with the blue arrow. He was still bothered with his diplopia. In fact, now it was even worse because now his images were kind of a little bit there in that field of vision and really disturbing him. And he was fed up of patching, but then he did vanish for 12 months and came back again. And this is just last week that he came back, and then finally he agreed for further strabismus surgery after 12 months, and this time we went to the left eye. So if we see over here, he has a left on right, that is the left eye is slightly higher as compared to the right, or we call it as a right hypo, but we can always balance the surgery by doing a little bit on the left eye, dropping down that left eye by recessing the superior rectus, and also balancing by doing a bit of medial rectus recession on that left eye. Still, it would not correct 45 to 50. Okay, so I was pretty bold, and we don't always, but there are cases where we have done a resection of that lateral rectus. In this case, the lateral rectus was pretty thin, so I've done a small resection of the right lateral rectus. He seems pretty cosmetic, day 1, day 2, with a very small esotropia, which I hope would fuse with prism. So this was one challenge which kind of went on for years together. Similarly is this patient. So he had thyroid eye disease, and his, if you see his MRI, his muscles are like really, he's done a lot of workout kind of muscles, really big, massive muscles. That superior rectus is so much more massive even compared to the inferior rectus on that right side. So his eye was fixed up, like just pointing to the sky, the right eye. He was fixing with the left eye. He was totally unhappy with the way his cosmesis was. More so his wife, who used to keep coming to the clinic with him. And he had undergone an orbital decompression, but this is what he looked. And it was only on the right side. After the orbital decompression surgery, he refused the left eye decompression. He said, I don't want to go undergo this surgery now, just go ahead with my strabismus. So I did, so this is just pointing to that super large muscle. So I told him that we do a staged procedure because he had refused the left orbital decompression. He underwent a supramaximal right superior rectus recession. I just put that muscle on a hang back, almost 13 millimeters back from the insertion. I just let it slide back into the orbit, and also coupled it with a right medial rectus recession. He's fairly cosmetic. However, he still has the diplopia. In fact, now he has even more bothersome diplopia. But then he sometimes suppresses the right eye, and we are still waiting for him to go ahead with the left orbital decompression and then do further strabismus surgery on that left eye. So from thyroid, we'll move on to trauma. With trauma, it can be quite diverse and quite challenging. This is a 28-year-old male patient. He fell off his bike in June of 2023, and he had his diplopia, which was more in down gaze. And when he looked down, he said that there is tilting of the images. So the tilting of the images was more on the dextro and levodepression. So when he looked down and right and down and left, and he used to work as a farmer in the fields. So every time he's looking down, trying to work with his crops, and he's getting this double vision, which was pretty bothersome. This was his eye position. So as you can see, all that double vision and the vertical deviation is more in the down gaze. In the dextro depression, he's got a right hypotropia, and the left, he's got a left. So he basically did fit the clinical picture of a bilateral superior oblique palsy with a torsional diplopia. You can see some underaction of that superior oblique on the, I don't know if this pointer would help me, but you can see some underaction of that superior oblique muscle on the right and left side. And looking straight ahead, he was ortho. So, it was very challenging to do a surgery on a patient who's straight ahead orthotropic, but just has this double vision, which is kind of not just, it's something which he has to deal with all day because of his profession. This was an excyclotorsion, which was noted on the double Maddox rod, which was very significant, as you can see even on the fundus photos. And so my options were just try and convince him to, just patch one eye, keep doing your job. And then he didn't really like it. He came back. We can't really give him prisms in this cases of torsional diplopia. And then the two options for surgery was either to nasalize the inferior rectus muscle and or do a Harada-Ito procedure. And I opted for a Harada-Ito procedure where the anterior fibers of the superior oblique, which are the torsional fibers, are then separated and moved to the superior border of the lateral rectus muscle. And this is the anterior fibers over here, which I'm suturing up. So he was pretty good post-operatively on his 9-gaze measurements, and this is what he looked on his 9-gaze, where he's got a very small exophoria. So that kind of ended well, but it's not always that simple. His torsion was also, or rather easy. This torsion was also much better when we saw him post-operatively. And when I say it's not always easy, is this other gentleman who gives a history of intermittent vertical diplopia now. He's unsure of when it started. Like, he's in his early 60s, and he says he probably had a fall at the age of 5-6 years, and maybe that's when he started, but it's all really sitting very vague. He has a small abnormal head posture. He has a left hypertropia, which increases in right gaze and left head tilt, though I would assume there would be some spread of cometance. He also has an inferior oblique overaction of that left eye, and his double Maddox rod again measures about 15. So this goes more, just because of the way the double Maddox is, I would think it would go more in favor of a bilateral, but an asymmetric superior oblique palsy. And these are his 9-gaze measurements. Again, as you can see over here, there seems to be some underaction of that superior oblique muscle on the right and left gaze while looking down to the right and left. And this is his fundus appearance. He is still awaiting surgery, but so this is always a discussion about what we can do, how much we can improve, how much do they really want things to proceed, and then take a combined decision. So incidentally, this is his imaging, and you can see these really tiny superior oblique muscles over here in both eyes on the coronals. So I don't know if it's just a long-standing atrophy sitting there, or what exactly is the story, which I can just explore and come to maybe next year. So let's go on to one more. So this is also a trauma with diplopia. So this lady, as you can see, she's just got heavy makeup on all the time because she tries to camouflage all the scars that she has on her face after the trauma. She has this strabismus, the double vision. She has a significant enophthalmos of the right eye, and she also complains of vertical and horizontal diplopia. She does have some limitation of abduction of that right eye and adduction of that right eye, and we've got a little video which I don't know if I can play this video. Okay. So this was preoperatively. So when she tries to move her eyes, there is there is absolutely no elevation, so it looks pretty uncosmetic for her. And she's a young, conscious female. The degree of makeup that she has is just phenomenal because she just doesn't like the way she looks. Anyway, so she went ahead with a horizontal muscles which was slightly offset, a recessed resect of that right eye, and she is much better. She has prisms and glasses now, which kind of help more with her double vision. So this was just a small little study, or not small, rather, it was a large data study, but we basically looked at strabismus following orbital wall fractures and looked at the incidence of diplopia that we've noted. A lot of them present with horizontal diplopias. Vertical and torsional are much lesser, but definitely there. So fractures is one big reason why patients can have some kind of diplopia which is not so easy to deal with. And coming to our lucky last lady, so this is a patient with disturbing diplopia. She's a 45-year-old female patient who had injury with, so she had a, I don't know how she managed to smash this wine glass. Not only was the wine gone, but also the injury of that glass pieces, it went straight to her eye. And then she had this double vision on looking up and down. And she came to me after quite a while, and she wanted a solution for her diplopia. Luckily, her eyes were good, her vision was good, but as you can see, those red arrows, these are pointing to those glass pieces which are sitting on the superior oblique and the superior rectus muscle of that right eye. The rest of the muscles, the globe, everything is intact. So when she looks up, she gets double vision. When she looks down, she gets double vision. And if we see her measurements over here, so as you can see, she cannot elevate that eye. It's like a little, it's like an acquired Brown. She can't even depress that right eye adequately in adducted position. And if we look at her 9 gaze, so she's ortho, or that's little sweet spot in the center, but when she looks up, the left on right increases. She looks down, the right on left keeps on increasing, and then she has to always try and move her head to find that particular area. I somehow decided to manage her conservatively because there was no point chasing those glass pieces, getting them out and looking at whether the scarring is going to change things or not. So this is a case of something called as a canine tooth syndrome, and she was best managed conservatively, given prisms for reading, and counseled a lot. So in conclusion, dealing with diplopia is challenging. We need to individualize our approach and management and try and improve the diplopia in primary and reading positions. I thank you very much for your patient listening.
Thank you, Manju. I think we had a question from the audience as to how do you manage the superior oblique palsy, if you can just at the same time.
I told right at the beginning, we have Rashman Gandhi sitting here, he's in Hyderabad.
I'm sure they must be wanting to
so basically, yes, thanks. So we need to first evaluate the superior oblique palsy. Is it an acute, is it chronic, and what is the cause? Because just knowing that it's a superior oblique palsy is not enough. Knowing the etiology is most important. Both whether it's a local or a neurological condition, whether it's congenital and acquired, because all of them will present kind of differently. But if you're looking at acquired superior oblique palsy who come with this kind of diplopia, after figuring out how is the diplopia, whether it is a vertical deviation which is acute, as in it's a left hypertropia, worse on right gaze, worse on left head tilt, so we know it's a left, then we need to find out which are the muscles you need to deal with. If it's a small angle, sometimes we can wait depending on the etiology, as I said, and treat conservatively, and depending on which muscle is overacting, then it's a surgical decision. But all in all, it takes a lot of detailed evaluation. But I would always give a lot of emphasis to knowing what is the etiology, whether a neuroimaging is required or not, because we don't want to miss anything which may be sinister in these cases.
Any role of prisms anytime do you use?
There is a role of prisms in such cases, especially if they're ischemic fourth nerves and they're going to kind of hopefully resolve over time. Then it can be used like a little crutch if patients don't want to cover one eye, and then just see over time if things are improving. It depends on the degree of deviation, but for that we first need to rule out that there's nothing else that we're missing.
Thank you.
Thank you.
Any other questions? Yeah, Rishi. Maybe you can come on still because it's going online.
Just a query about the double Maddox rod test. I mean, not all cases will have like right eye going up in left gaze and the left eye going up in the right gaze in a bilateral superior oblique palsy. Is there any demarcation beyond which degrees it is a bilateral superior oblique palsy? Or, I mean, clear cases which are not clear.
So usually 8 to 10, more than 8 to 10 on a double Maddox rod would point towards a bilateral involvement.
Yeah, please.
That's a great question. So if things are improving slowly, we can wean off the prism. As I said, prism is sometimes like a crutch, and it may delay the improvement as compared to a monocular patching or letting the patient being able to try and fuse. But as long as a patient is comfortable, they can even go on for years together with prisms. It's not something or an indication which is interim or surgery is the only option. It's very patient-centric. So there are patients who may not want and they're happy. It's just a prism that could be just ground into the glasses and they may be comfortable. So you can just go on with it.
Recently, we had a child complaining of diplopia for the last 3 days. He had this complaint, and similar episodes were there earlier also during the last 3 years. And when I examined the child, he was like very clearly mentioning that he had appeared for his examination, and when he was trying to write on the answer paper, few of the letters, few of the words he was writing properly, and then the words were like different sizes. Some were like bigger, some got smaller because of this diplopia problem. And when I went through the clinical record, it was mentioned Miller-Fisher syndrome. I asked the detailed history also, whether there was history of areflexia or anything. He had some issues with like walking, but as such there was no areflexia or nothing like that was mentioned in the case sheet. Now when I have this patient complaining of diplopia, I did the diplopia charting. It was right gaze completely involved, double images, primary and left side slightly, but then the responses were varying. It's not very clear cut, I mean the way we chart the diplopia charting, we do the diplopia charting. So how should I approach the case? The earlier MRI which was done in this case, that was normal completely.
Right, so there'll be a lot of factors. First of all, this looks like acute on chronic diplopia or something which is kind of variable intermittent. We need to know a little more details about how is the vision, the refractive error. So as Rohit and Dr. Rashman have said initially, we have to rule out all these causes, whether it's really a diplopia or not in children, and whether it's their ability to, like if it's something comitant or if it's something related to more close work or near work. So in the context of Miller-Fisher also, I would involve a neurologist as well and see what was their previous scans or reports or what treatment they had. It's not just diplopia, which, we are just...
neurologist, actually, they had this doubt on this diagnosis, Miller-Fisher syndrome, and that is the reason they referred it to ophthalmology.
Sure, maybe Dr.
And
Clement.
the extraocular movements were completely normal, everything. Like, I couldn't make out what could be the reason there, why this child, and the child was quite, good in studies, so there was no reason to, question me also. It was very affirmative. This is where I can see double images, this is where. And right half of the case, it was like perfectly. Every time it is the same place, same way.
It's interesting you mentioned that. So first about Miller-Fisher, if the patient is already out of the acute phase, and all has been done, you're just waiting for the binocular diplopia either to get better, or if there's a permanent deficit at the end, then maybe that will need to be fixed. But in this case, the history sounds a little bit different. What is interesting in what you mentioned is that he says the images with one eye are bigger than the other eye.
Yes, he showed
is
me
is that with his glasses or without his glasses?
with his glasses. He was wearing glasses and the refraction.
So one of the things we may need to figure out first is why the images are dim, because it sounds a bit more like there's some aniconia going on here. And so that if there's a difference in the refractive error, a very observant child might notice that he cannot really fuse the images very well, and that may also be conditional upon the type of glasses that he's wearing. On the other hand, you might want to have then a look at the macula and see why, is there a reason why one eye has a larger image than the other. So I might head down that way, and then also in your charting, do the measurements in the different gaze directions to see if there really is a difference in the images, a difference in the measurements when he's looking.
The distance between two images.
Yes, that's not the difference, but what you measure on the prism cover test in the different positions of gaze. So that might be helpful, at least to just get a little closer to the answer. I'm not sure we'll have a direct answer for you straight away today, but that may be the direction to hit.
Yeah, we were like totally directionless now. At least we have something. Thank you so much.
And I think if the patient had a history of Miller-Fisher, how soon you have seen the patient after the acute management?
Ma'am, the last two episodes, like, it was kind of annual. The first 2 times he was given steroid, IV steroid he was given, and he recovered. This time when he had this complaint, it started 3 days ago, and on day 4 we saw him.
There was no associated headache or any other features?
No, ma'am. We had one ENT consultation also. Like if we are missing something.
Yeah, because if we are just going in one fashion, recurrent episode, child having a diplopia, it doesn't behave. Miller-Fisher is usually a single event after a viral illness or something, and most of the times it responds well to the acute management. We give some time, and then we see most of these children or adults with a Miller-Fisher. We give a time after an IVIG or so. By 4 to 6 weeks, they do mostly well. They do respond.
Unless they go into Guillain-Barré, otherwise.
That's the difference story. Yes.
If you're having recurrences far apart and that respond to steroids, I might think of myasthenia.
Exactly.
So something
But
else.
yeah, but something else. But maybe not be myasthenia, but I'd have a closer look at some of all those other
Ophthalmoplegic migraine or something?
yeah, ophthalmoplegic migraine. Have a look at the orbits as well, and see what's going on there. If it responds to steroids, something is happening as well. So you've got 2 good clues there. One is the NIC cornea, and the other is the response to steroids. Yeah, an episodic character.
Thank you so much.
I actually had a question for Manju. When you are fixing a torsional diplopia, now it's always very difficult to even measure torsional diplopia except on the double Maddox rods. But how do you estimate how much to put the muscle to fix the torsion?
So, yeah, I mean, it's a very difficult question to answer.
Sorry.
But when I'm doing a surgery for torsional, especially in these cases of superior oblique palsy, many a times taking a decision to do a Harada-Ito itself, I need to think that am I going to be able to really help this patient or not. And often I feel that nasalizing the inferior rectus is easier because then you can just put it back if it hasn't helped the patient. But Harada-Ito, somehow it just works. And I've done a few of these, and I somehow like that surgery. It's kind of become my preferred surgery. It just works. It just improves that torsion to a huge degree. Not always it will be perfectly set, but it does improve it to a lot degree. And sometimes the way the trauma is that they sometimes have to live with some degree of torsion, and we can at the most improve things but not fix it.
Yeah, if anybody, Rishi or anybody has any comment on that?
Most of the strabismus surgeries we have, clear-cut rules or algorithms. When this much amount of degree will, but when it comes to Harada-Ito, I think there is no way that if you fix the superior rectus this much away from the inferior lateral rectus, will get this much amount of torsion. But it does work. Always, most of the time it does work.